Thanks indeed, everybody. Thanks for coming out. Thanks in particular to Dr. Landro and Dr. Popovic, who I know have done an awful lot of work to get this conference going, and it's great to see so many people from many places here. What I thought I'd talk about today is something that's typically considered a surgical management for an athletic patient, but I think there are some options that we have in the conservative sphere. And that's with valgus extension overload. So the big enemy of the throwing athlete is putting your arm at this particular position. And why it's such a big deal is that at this point the amount of varus torque is about this number. You don't need to know the number, but you need to know about half of that's borne by this medial collateral ligament. And every time you do this, it comes very close to the failure load of that ligament. As Dr. Popovic pointed out yesterday, the failure loads are described by cadaveric elbows, but these guys clearly undergo a hypertrophy of their ulnar collateral ligament. It's also worthwhile bearing in mind that another third of the force preventing this valgus extension and subsequent injuries elsewhere is borne by the radiohumeral joint. So to give that some real-world ideas, and it's useful to have this in terms of knowing what we need to put our athletes back through. I just got bored when I put that many balls into the animation here, but there should be 125 baseballs here, or about 18 kilos of load. Or you can also consider that here at the radiohumeral joint, we've got about 50 kilos of load going through an area about the size of your thumb pad. So what can we do conservatively to minimise valgus strain? And there's 5 different things that I'd like to now touch on, some of which we can change and some which we probably can't touch. So first of all, I'll talk about the ones we can't touch. We're all now pretty well aware that the total rotational range of motion is the thing we should be considering, not just external or internal rotation range. And first documented in handball players was the notion that the amount of twist about the long axis of the humerus, the humeral torsion, effectively shifts this total rotational range of motion. So our throwers look like this, not because their anterior capsule's been stretched and their posterior capsule's been tightened, but because they acquire this side-to-side difference in the amount of twist about the long axis of the humerus. So somebody with a retrotorted humerus looks like that, and they're going to appear to have more external rotation at the expense of the same amount of internal rotation. Now, it turns out that this amount of twist about the long axis of the humerus is changing throughout, especially your first 16 years of age. And the window seems to be between 11 and 16 years. The amount of throwing that you do allows you to effectively keep some of this retrotorsion that you're born with. So that your adult amount of torsion is partly determined by the amount that your parents give you and partly determined by the amount of throwing that you did between the ages of 11 and 16. So when we compare the non-dominant arm, essentially that's going to be genetically determined, while your dominant arm is a sum of your genetics and the amount of throwing activity you did. And that's especially for Dr. Cassidy, El Guapo, and probably the only other Red Sox fan in the audience. So in looking at the effect of humeral torsion on the incidence of throwing injury in 35 high-level adolescent baseball players, we followed these guys for 30 months, and we looked to see how many of them received injuries or not, as opposed to their amount of humeral torsion. In that time, about 20 of them got injuries, and when we looked at their dominant arm torsion and non-dominant torsion, so on this graph, down here is a more retrotorted arm, up here is a less retrotorted arm, and in the dominant arm there's no difference, but in the non-dominant arm you can see this large difference. So it's effectively in large part genetically determined, or the other way you can think of this is to throw this much at this level, you need to have this much retrotorsion, and if you started from there and had to get here during your teenage years, you're going to be at more risk of injury. Not career-ending. Maximum of 3 injuries over 30 months is 1 every 10 months or so, so it's clearly not horrible. What about adults? Now, I've only just been made aware of this research. In fact, to my knowledge, this is the first time it's been presented, and I'm indebted to Mr. Lonnie Soloff from the Cleveland Indians baseball, who looked at their major league pitching staff over the last few years and measured their amount of humeral torsion, and they substratified them into relatively trivial injuries to the more significant injuries. These are the ones that they really want to prevent. And they found with their adult cohort that every extra degree of retrotorsion made you about 10% less likely to get one of these injuries. In a practical sense, of course, we're not going to do rotational osteotomies on these guys, But what it means is somebody who's got lousy retrotorsion, we pay a lot more attention to their complaints or their symptoms in terms of pulling them out of their activity. The big villain, or the big victim, I guess you'd say, in valgus extension overload is attenuation of the ulnar collateral ligament, and that's what we're trying to avoid. So when the throwing athlete has to put their arm back at this position, we want as much as possible for it to happen not here at the elbow in terms of valgus stress. So the more that we can get to happen at the shoulder, the happier we are. And there's a little bit of a trick here in taking people from this position to that position. It's tempting to grab a hold of their hand and try and stretch them back into that direction, but clearly that's going to open their elbow up and cause us grief. So what you need to do when you stretch these people is in fact grab a hold of their arm and rotate them back to stretch like that without touching their forearm. So now I can get a stretch here at their shoulder into an external rotation, but without placing valgus stress across the elbow. An absolutely big area that we need to look at are the way that the individual throws, and there's 4 particular avenues for things that we can change here. Firstly, with regard to the amount of external rotation at stride foot contact. So this is at the point where the front leg hits the ground. What we're looking at is the amount of shoulder external rotation. Should be about 50 degrees or so. And if you increase that amount of external rotation at that point of stride foot contact, we get about another 0.7 of a newton per degree. So to give us some idea of orders of magnitude here, 10 degrees is going to give us 7 newtons, and that's only about 2% increase. 2% though, when we're coming very close to failure load for the ulnar collateral every time, suddenly 10, 20, 50 degrees, and we're starting to get into a little bit of trouble. If you go in the opposite direction though, it's better news for us in that for every 10 degrees we actually lose that amount of force that's going on the elbow. A tiny little bit more. The thing here that we have to watch out for is, though, while you're sparing the valgus strain at the elbow, we're actually increasing the amounts of force at the shoulder. Next one we can look at is the amount of elbow flexion or extension at this point of stride foot contact. And this is one of the odd ones where it turned out that the coaches were wrong. Coaches will typically say that the hand has to stay outside the elbow or relatively less elbow flexion, and it turns out that having more elbow flexion at this point is protective of valgus strain. Next one, second last one, is the amount of shoulder horizontal adduction. So that's this movement from horizontal abduction to horizontal adduction. And it turns out that the maximum amount of horizontal adduction is proportional to the medial elbow force, this time at the rate of 2.5 newtons every degree. 10 extra degrees, 25 newtons. The maximum is 270, so 10 degrees can give us almost 10% extra force. So that's a big avenue for change. Final one is the amount of shoulder abduction, this time again at stride foot contact, and that's proportional to valgus stress. And this is one where probably lower level coaches might make a mistake. Lower level coaches will tell people not to throw with their arm in less abduction, and they want them to get their arm up higher. But it turns out that this, in fact, increases the amount of valgus stress at the elbow. How much throwing? We've talked about what making one throw does to the amount of load, but clearly if I make too many throws, then I'm going to pull this apart. And here we need to consider the total number of throws you're doing every week and every outing, and it really depends on the age. I won't bore you with the details. You can chase this up with me later if you like. But these in baseball are very prescriptive, and my limited experience with handball says we don't monitor the load nearly as much as we do with the baseball players, and perhaps we should be. A great thing to tell your players is that this paper from Olson in the American Journal of Sports Med showed that if you throw for 8 or more months of the year, you had a 5-fold increase in requiring shoulder and elbow surgery. And if the players threw with a perception of fatigue in the previous year, they had a 26-fold increase in the incidence of shoulder and elbow surgery. Getting back to throwing, they can't be better in the clinic and then let loose, because the first thing a thrower wants to do is throw as hard as they can. We need incremental increases, and they're eventually going to throw, depending on if they throw maybe 70, 80 miles an hour, 90 to 100 miles an hour. And really importantly, you have to go backwards if they get any symptoms. They can't be let loose and told to just make things tougher and tougher. Physios only ever care about strength, of course, so we want to think about the strength at the shoulder and at the elbow, and there are a couple of avenues for us here. It turns out that the amount of peak external rotation torque, which is of course determined by your external rotation strength, the more external rotation strength you have, reduces valgus stress. The numbers for us to remember here is that your external rotation strength should be about 20% or so of your body weight, or if you're taking 15% of your body weight, you should be able to do about 20 repetitions. At the elbow, theoretically, the potentially prophylactic muscles, pronator teres should have the longest lever arm, but the anatomic studies say flexor carpi ulnaris and digitorum superficialis are the ones that overlie the ulnar collateral ligament in most subjects. It makes sense to be strengthening all of these though. So in summary, how can we, without surgery, try and reduce the amount of valgus strain, or post-surgery get rid of the valgus strain? We really need to pay attention to the humeral torsion, but this is affecting adults and adolescents in a different way. When we stretch to external rotation, watch out for that ulnar collateral ligament. Tragically, you can't just look at somebody throwing and show what these things are. And even just normal speed video probably doesn't cut it either. You really have to do high speed analysis. Absolutely, the elephant in the room is the throwing volume, and we need to be doing at least once they've injured these strengthening exercises, but almost certainly prophylaxis as well. Thanks very much.